So I'll be your first presenter this morning. I'll be giving you a field report on the implementation of maternal death surveillance and response in Kenya, incremental progress made and lessons learned. So this report or work was published in around 2017, and after my presentation, listeners will come and add more in terms of what we have done as a country after we developed the confidential inquiry into maternal deaths from 2017 going forward. So, my name is Martin Nainga. I'm a technical officer in the School of Political Medicine. So, the structure of my presentation will just be introduction, aims of the report, methodology, then key findings, where we'll be discussing more about the experiences of confidential inquiry into maternal death assessors, and also looking at the experiences of the Ministry of Health staff and challenges and lessons learned during the development of the confidential inquiry into maternal deaths report, and also in terms of implementing maternal deaths and response in the counties and also at the national level. We will have contribution and also recommendation. So to start us off, we are being told that the MPDSR constitutes a policy improvement approach that is approach to identify the first thing that needs to be identified, the number of maternal deaths occurring in our facilities and also in our communities. Then we need to know the underlying causes of these deaths and associated factors. Then implementing action to reduce the number of preventable stillbirths, maternal and neonatal deaths. And as a country, our key emphasis going forward is mostly on the action part, the recommendation, because as you were told yesterday, you can do the sit down, do the audits, but if you go ahead and you don't do any act on the actions developed, you'll find that the quality of care will not change. So we need to be very keen in terms of the response part of the MPDSR. The maternal mortality is often described as the litmus test for our health system. It's just it shows us how a health system is able to respond to women's health, especially during pregnancy, in labor, and also after pregnancy. How our healthcare system able to handle these women. And it re-emphasizes the implementation of timely reporting of deaths and implementation of action to prevent future deaths. So in terms of reporting, we have notification, which is supposed to be done immediately maternal death occurs, and also the issue about auditing should be done within 7 days. So those are some of the things that we need to work on. So implementation involves establishing a system to link both surveillance and review of maternal deaths at facilities and also at the community level. And as you all understand, the issues about the MPDSR, especially at the community level, are still, we have not maximized the use of verbal autopsy in our counties. So we need also to work towards ensuring that community deaths are also audited and accounted for. The government of Kenya made maternal death notification mandatory and introduced maternal death review in 2004. And between 2004 and 2006, we are being told that only 46% of all our maternal deaths were reported via the health management information system, were notified and reviewed. So that's a very small number. And in 2019, Kenya launched the facility-based maternal death audits in our facilities, and then new documents were developed to include advice notification form and also a more detailed review form. And when we were introducing this maternal death and review in the country, our key emphasis was on no blame approach.
The other recommendation was to strengthen MDSR notification. So generally improve MPDSR in counties so that we can have processes going on as required, committees being present, making the right recommendations, and also following up actions after the recommendations. The other recommendation was to standardize documentation So one of the findings was that there were challenges in documentation, and I think Martin has highlighted that. And with regard to this, there was one of the other recommendations was to explore use of electronic medical records. The other issue or the other gap that had been identified was the diagnostic services. So the recommendation was to expand this with a focus on improving the diagnostic tests, especially at the point of care, maternity and labor ward. And then also the other recommendation was to improve blood supply, that is in form of blood itself and other products of blood, and making or adopting innovations to improve blood and blood supply. The other recommendation was to provide up-to-date treatment protocols, and especially those that were user-friendly, so that the maternity healthcare providers could access the treatment protocols easily and be able to provide the treatment accordingly. The other was to embrace use of technology. And some of these recommendations also touched on what the county was to do. And that is why we have now the national and county level. And mainly here was capacity building in terms of EMOC training, and also capacity building, especially at level 4s, where we found quite many challenges and many referrals coming from that point. Building capacity in terms of spinal anesthesia. And then retention, I think we discussed that yesterday quite broadly, where you train health workers, but then the retention is a problem. So again, this was a recommendation to make sure that the staff that are trained and that have the skills in maternity are retained, and at least for 2 to 3 years, so that they can provide the necessary expertise. And then the other was to also make sure that we have competent and experienced healthcare providers at the point of care. It was one of the challenges and one of the gaps that was reported in that CMT was that the availability of staff, experienced staff, was a problem at the point of care. So staffing with experienced competent staff was recommended, and also ensuring or exploring how to do this model of enumeration, especially in areas where we have challenges of the healthcare or the experienced specialized healthcare providers like obstetricians. And the other was documentation, which again Martin has mentioned is a major gap in terms that was identified in the CMD process. Now, at the county level, one of the recommendations was to strengthen the availability of comprehensive emergency obstetric and newborn care, but also basic emergency obstetric and newborn care. So facilities are there, some are referred to as CMOC, others are referred to as EMOC, but they are at different levels of functionality. So one of the recommendations was to increase this up to greater than 70%. So adopt strategies to increase, including performing EMOC functionality assessments, to assess and after that take action to ensure that our facilities are well equipped in terms of providing comprehensive emergency obstetrics and also basic emergency obstetrics and newborn care. The other was capacity building, as I mentioned, and then availability of specialists, mainly the obstetrician, improving documentation, I mentioned that, and then linking maternal newborn health to critical care. One of the findings was there were challenges in mothers accessing intensive care, and that is where that recommendation was made. At the facility level, the recommendation was to provide minimum package for antenatal postnatal, and then improve the monitoring of ANC labor and delivery. One of the gaps identified again were challenges with monitoring of also conducting of regular audits and giving feedback to the health workers so that they can improve the quality of care. At the community level, the recommendation was to strengthen community limits by improving the facility linkages. Again, this was a method of improving the MPDSR process because there was, or it was identified that there were many deaths that were occurring in the community. And providing this linkage would provide
to make sure that the process is completed, so that the deaths that are happening in the community can be reviewed at the community level, but then reported by the leading facility. And then strengthening good reporting, mainly through verbal autopsy. So as I said earlier, I'm going to limit my discussion or my presentation mainly recommendations that were implemented at the national level. So the first one, providing a relevant policy and legislative backup for CMP process and generally MPDSR process. Now here, I would say that this area we still have a lot to do. It is in work in progress. The enactment of the MPDSR bill and the gazettement of the National MPDSR Committee is still work in progress. The vision of reproductive maternal health is still working on this. But again, these areas or these challenges also relate with regard to the challenges that we are having with regular meetings of the National MPDSR Committee. But however, the Constitution provides an environment, a good environment for quality reproductive health services. But I would like to emphasize that this bill is very important so that we can anchor CMD process and general MPDSR process to the legal framework. And then the National MPDSR Committee, as I say, where the appointment was done, the assessment has not yet been done, and this needs to be done. And also there was recommendation that we need to include female advocate or a judge in the committee. Again, this is work in progress. This has not been implemented. So this is a very important
point or recommendation for us to have good progress as a nation. The next recommendation was to strengthen MPDSR notification and generally MPDSR. Here, a situation analysis report was made in 2019 regarding the MPDSR implementation in the country. So assessment was done generally in the counties. And of course, different counties were in different levels of implementing MPDSR. And after that, the Division of Reproductive Maternal Newborn Health engaged in capacity building of the committees so as to strengthen them and to make them functional for MPDSR process. And still, as part of implementation, the DRMNH developed the National MPDSR training package so that the training in the country was to be standardized, so that what is happening in Isiolo can be what is happening in Mombasa, and to make sure that that was sustainable. 64 national trainers were trained, and these are spread in all the counties. And currently, work has been going on. These TOTs have been instrumental in implementing, in training healthcare providers in the counties with regard to implementation of MPDSR. Then printing of MPDSR tools have taken place. Many counties have already collected their tools, but we still have some still to collect at the Division of Reproductive Maternal and Newborn Health. The tools were similarly reviewed, so we have new tools that have been reviewed, and these are the ones that are being distributed. And again, updating happened at the KHIS, so that what was reading in the tools, the hard copies, is what was also reading in KHIS system. The other recommendation was to improve the quality of documentation, and here a two-day stakeholders meeting was held, and the intention was to review the maternity file and also the newborn file to make sure that we have standardized files, because as it is, different counties and different facilities, even in the same county, different facilities have different maternity files and newborn files. And this was a way of improving documentation so that we have standardized admission forms, history and examination details. The idea was to improve documentation, and again, by extension, to improve the MPDSR process. Because as Martin mentioned, an improved documentation will also give quality data to MPDSR process, so that what we analyze and what we report is the actual situation. And a QOC, the quality of care standards that was developed, has established the documents that must be there in maternal and newborn health services. So this document is existing, it is developed, and it establishes the standard for the documents that we require for maternal and newborn health. The other recommendation was to have regular and mandatory updates on EMONC. This was one of the recommendations. And at this point, most of the counties are now conducting EMONC trainings. There is an EMONC training package developed by the Division of Reproductive and Maternal Health. And this is what they are using to train their health workers. We already have the trainers in the counties. And they are also anchoring the training of EMONC into the annual work plans and budgets. So this is going on. So this is quite a good progress in this area. And again, the mentorship package was developed, as I have mentioned, and is being disseminated in the counties. So far, dissemination has occurred in 6 counties. 21 counties are planned for further dissemination. We are yet to get the funding for 20 counties dissemination. CPD points have already now been anchored in the Nursing Council and Kenya Medical Pharmacy and Dentist Board in terms of EMOC training, so that it becomes part of renewal of the license that we do regularly. And then the other thing that has happened, which is a very major milestone, is that a pre-service task force was formed, which has been overseeing the review of the syllabi in the with regard to EMOC and MPDSR, and this has happened. And 383 lecturers have been trained after the review of the syllabus, both in the midwifery and clinical medicine, what they call the reproductive health curricula. And this review of the syllabus is both in the basic and also the post-basic syllabi. Here is a picture on the left, is the review of the midwifery syllabi, and then on the right is the reproductive health curriculum for clinical medicine, so that we have EMONC anchored already in their curriculum. And this is proven to be sustainable. The in-service training, people forget, or people get transferred, but once you train them at the pre-service, then these health workers will graduate with the skills already with them. Now, the other recommendation was improving the blood transfusion services. One of the challenges that was identified with CMD is inadequate blood supply in facilities. Of course, we know blood is an emergency commodity. And here work is in progress, again, between Division of Reproductive Maternal Newborn Health, together with the National Blood Transfusion Services, to remove the bottlenecks that are there in terms of blood transfusion services. And the National Blood Transfusion Services has developed an advocacy and what we call an implementation plan to make sure that the blood transfusion service is providing the adequate service, and also ensuring that there is intensive blood donation campaigns. Counties are also conducting blood donation drives to make sure there is sufficient blood in their counties. And some also have blood banks. But some, as you can see at the bottom there, counties are also coming together to make sure that they develop regional blood banks to ensure adequate blood supply in their counties.
So I'm going to present to you, sorry, I've been having a call with So I did a study of the factors for maternal mortality among women who had cesarean delivery in Kenya, and this was a study that was based on whose data was taken from the first EMP that my colleague has just presented. And we were able to publish it in the East African Medical Journal, and my co-authors were Dr. Pamela, Dr. Helen Alot, and Professor Charles Hami, who was my supervisor while I was doing a presentation in LSTM during my MSc studies. So if you want to have a look, maybe more details about the paper, because of the detail, you can go ahead and check it out in the East African Medical Journal. So what was the background of this study? We see that Kenya is amongst the top countries that have been ranked to have a very high maternal mortality rate in sub-Saharan Africa. This was according to the WHO report of 2015, and I don't think it has changed much over time. And the MMR at that time, in the year 2015, was 710 deaths per 10,000 live births, which is quite high, compared to the target that was given in the SDG 3 of 140 deaths per 1,000 live births. Then again, we're going to say that for us to be able to lower the maternal mortality, cesarean section is a very important procedure or surgical procedure. We think it's life-saving. If a mother has developed complications and there are implications to have the cesarean section done, then once we do it, we're able to save a mother's life. So cesarean section has really come in handy to be able to save quite a number of maternal lives. But however, we see that over time, there's been a debate of whether cesarean section actually improves or the rate. The higher the rate, because now we're saying it is life-saving procedure, right? So now we ask ourselves, if we have very high or quite high rates of cesarean section rate, then does it mean that we are going to save more mothers and hence have lower maternal mortality rates? But we see that over time, it's been a debate that has been ongoing, and it's actually been proven that it's not linear. The relationship between the CS rates and the maternal mortality rate is not linear. So it does not mean that if we have a rate of maybe 20%, then our maternal mortality rate will be less. And then we see that maternal mortality rate and morbidity is still high, as I'm explaining, even with the CSS that are going on. And also it has got quite a number of complications because it's a surgical procedure. So we are also seeing that we are having a higher prevalence of mortality and morbidity amongst those who are undergoing cesarean section compared to those that are having vaginal birth. And here is a picture globally where we are also saying that an increase in maternal, not maternal, but cesarean section rates does not immediately or automatically translate to lower maternal mortalities. And you can see on the far, this is to you, it is your right, on that graph on the right, it's showing different CS rates in different countries. You can see Bangladesh quite up there, over 60%. Myanmar is there, Pakistan, there's Egypt. Then when you go down amongst those countries that have quite a bit lower rates of cesarean section, that is South Sudan, the Gambia, and Burkina Faso. But we are seeing that when you compare these ones in the different countries, you can see all the rates are really quite high, and it cannot be compared with the CS rate that was recommended of 10% by WHO in the year 2013. Actually, the recommendation was 10 to 15%. Most countries are actually, if you look even at that graph, are way above the 10 to 15%, but still that does not translate to lower maternal mortality rates. The graph down there is the Kenya CS rate trend between 2014 and 2017. You can see even in Kenya, the picture is not any different. The cesarean section rates have been going up from the year 2014 to 2017, but still when you look at our maternal mortality rate, it does not translate to lowering of the same. So there's the Robson 10 group classification that was developed and an implementation manual was actually published in the year 2017. So this is a tool that was proposed, or a tool that was developed so that we can be able to assess, monitor, and also compare CS rates within a facility or different or within settings that are more or less the same. And it focuses mostly on the obstetric factors, that including the parity of the woman, the gestational age, also the presentation and the lie of the baby or the fetus, and also the number of fetuses. So this has been helpful to see whether to compare whether those CS rates are actually translating to an improvement or not. So the rationale of the study, first of all, we have already mentioned that we based our data on the first CMD. So from this report, 37% of pregnant women who died during that time had actually had cesarean sections done, which translates, that was 138 women. So then our question was, this is a life-saving procedure. Why would a woman go through a cesarean section and still end up dying? So we wanted to look further and see, do these women have different, specific characteristics that predispose them to dying even after having the cesarean section done. So we wanted to determine the risk factors that were associated with mortality
and this would facilitate in us developing context-specific actions to reduce the risk of maternal death. Because if I know, for example, that maybe parity is a risk factor, then when I have a woman who is multiparous, then I would be on the lookout and give more care or quality care or follow up more closely so that that woman does not end up dying. So that's why we went ahead and did this study. So we had 3 objectives. The first one was, first of all, to determine what the risk factors were based on the population that we had. That was the women that died after having cesarean section in the year 2014. And then we also wanted to assess whether it's feasible to apply the RTGC in Kenya, and then also develop recommendations for us to be able to improve the quality of care. That diagram simply shows the Robson 10 group classification. It's quite small, so maybe I'll just try to explain it. So right at the center is the Robson 10 group classification that bases on obstetric and clinical factors. But we know that obstetric and clinical factors are not the only risk factors that predispose a woman to mortality or morbidity. So that the obstetric and clinical factors are surrounded by community factors, they are surrounded by healthcare provider factors, they are surrounded by the women themselves, their characteristics, all those factors. So that's why there is that big circle as we keep going out from the core of the circle. So we used the case control study. So we had cases, those are the women that had actually died, which was 138. And then we had controls. Those are women who delivered in the same year, in the very same facilities where the maternal deaths occurred, so that now we are able to compare. These women have different characteristics that were in the ones who died. They have some characteristics or risk factors that these women who were able to survive after the cesarean section in the same year, miss or not have. So we had, so after doing quite a bit of cleaning up of the data, we had ended up with 126 women as cases. Those are the ones who actually, the ones who died. So we were using case notes of these maternal deaths. And then the controls, we used the 1:2 ratio. So we had 252 women who actually survived after having cesarean section in the same year. And then we used multiple regression analysis using the SPSS software. And we came up with adjusted odds ratio with a factor of 0.05 for us to be able to determine the risk factors. And we also checked for completeness of data so that we could be able to apply the RTGCS to both cases and compare them to the control. So these are our results. Postpartum hemorrhage was one of the risk factors that was identified after we went through a very thorough process of data analysis. We had a parsimonious model that gave us the following risk factors. So postpartum hemorrhage was the number one there with the odds ratio of 27.5. The confidential interval is stated on the table. Then the other risk factor that was identified from the study was blood transfusion. So if a woman went through blood transfusion, they had the odds of mortality at 14.5. And another one was referral to ICU. So if a woman went through care and the study identified that they had a risk of mortality at the odds of 27.5 with that confidence interval. And then the use of general anesthesia was another factor that we identified. And this was done after we had controlled for several confounders. So going forward, 45% of the women in our sample were having their first-term baby following spontaneous onset of labor. This is class 1 according to the RTGCS classification, and 33% had a previous scar, which categorized these women into category 5 of the Robson 10 group classification, and then less than 10%, that is 24, had missing data in the control group to classify the births using the RTGCS classification. So going back to the risk factors that we identified, we see that most of these risk factors are modifiable and they are related. Because we have talked about postpartum hemorrhage, we've talked about blood transfusion, we've talked about ICU care, we've talked about the use of general anesthesia, and the other one was
sorry. The other one also was having gone through ICU care. So you can see all the factors are quite related and they are modifiable. So these are factors that can actually be mitigated. When you look at PPH, for example, it's the leading cause of maternal death, right? Actually, if you can rank those risk factors, maybe the highest, factor with the highest risk factor there. So you can see this PPH can actually be prevented, right? And it can be modified. And you can have, you can think about things like NC visits where we can be able to pick women who are anemic in good time and intervene in good time, and all those other factors. Blood transfusion, by the time we are transfusing a mother, it means that their HB is quite low, right? And they are quite anemic and they have lost quite a bit of blood. So you can see all these factors are just quite related. And we can actually, there are things we can put in measures, we can put into place to be able to mitigate them. So these are the recommendations that we came up with. First of all, we need to identify the women that are at risk early, meaning that ANC is very important. So we need to really encourage these mothers to come for ANC visits quite early. One of the things that we have observed over time is that most women wait for third trimester to come for ANC visits. And so some of these risk factors cannot be identified. But if they can be identified early, then we can put up measures, we can treat the things that we are going to see as red flags and be able to prevent PPH. Use of regional anesthesia where possible, because we can see that general anesthesia use was one of the risk factors that we identified in the study. A lot of work has gone into, even as the predecessor speaker has talked about. Blood transfusion is one of the areas that a lot of work has gone into, so that we can be able to improve our services to the mothers. And so this is also one of the recommendations that we came up with. In terms of the RTGCS classification, we used it retrospectively, but ideally it's supposed to be used prospectively. So our recommendation is that if we can be able to implement it prospectively in different settings, it can be able to help us assess, monitor, and also compare the CS rates in the different settings that we have. So in conclusions, if we are able to prioritize interventions and also the interventions that we have mentioned in the recommendations, and also use the RTGCS classification in a prospective way, and also use it to analyze our CS rates, then that can be helpful to mitigate the risk factors that this study identified. And also we have said that we can combine the classification system with maternal and perinatal death audits, which is what has gone before, the presentation that has gone before us, will be quite helpful to reduce the maternal deaths after CS cesarean section in Kenya. Thank you very much for listening to me. I'd like to acknowledge our sponsors, our partners, our funders, some of support that we have received, some of whom are in this room. Thank you very much.